Para mí es un real honor y placer presentarles al doctor Pasquale Santangeli, quien es cardiólogo, epidemiólogo y entrenado como electrofisiólogo en Stanford University y la Universidad de Pensilvania. Actualmente el doctor Santangeli se desempeña como profesor asociado y director de la unidad de arritmias ventriculares en Cleveland Clinic, en Ohio. El doctor Santangeli es uno de los más prolíficos investigadores a nivel mundial en el campo de la electrofisiología, con más de 500 publicaciones. Es editor de journals como Circulation, JACC, y uno de sus principales tópicos de investigación es precisamente la predicción de riesgo y manejo de la descompensación hemodinámica aguda en pacientes presentando arritmia ventricular. Y pues es un honor para todos nosotros, un privilegio tenerlo. Thanks, Pasquale, for accepting our invitation and for coming to this ground round. You're going to talk to us about a very, very important topic, specifically because we're interested in organizing a BT unit, because regionally there is not precedence about group aimed to care these patients. So, as you know, we have a lot of challenge disease, etc. And it is important to understand from and to learn from your experience how to organize this care. So, welcome again, and thanks for accepting our invitation.
Thank you, Luis. It's a really pleasure and honor to be here. For the incredible with long time now. I was wanting to have here. So I'm happy that this worked out well this time around. All right, so this is really not just EP. I'll talk about something that has interested people in general cardiology, heart failure. We EP had to work with all of our colleagues very crucial to improve the outcomes of our patients. And this is really we're talking about risk and how to manage risk for patients coming to EP ablation, particularly the ones with advanced heart failure. So I will start off saying that catheter ablation of patient with structural heart disease it's just like a team sport. And I'm from Italy, I like soccer, so for me it's the same story. And so you really have to have a full team with you, not just AP. And the start of the team, it's not a single person that will resolve the issue. You have to work together with your colleagues from heart failure, from imaging, and so forth, from surgery sometimes. And this helps a lot to because they give you different perspectives on how to manage patients, how to improve outcomes eventually. So I'm a strong believer that a multidisciplinary approach to patients with BP, structural heart disease, will improve outcomes. I'll show you a pilot study that's done before leaving Penn, actually, in that sense. So you do need the expertise in catheter ablation, that's what EP does, but you also need to know, you have to have your team, people that know how to manage advanced heart failure, decide when it's appropriate to use hemodynamic support, what type of support device, and also the timing of implantation and removal. And also, this is really crucial. You need to know what is the exit plan for these patients. You need to know the patient eventually, after even a successful ablation, may have an exit plan in LVAD, transplant, or no exit plan. Some patients have no exit plan, and therefore we modify our approach sometimes. And also not collecting data, we introduce it in our also palliative medicine. Because in some patients, we decide with them not to operate because high risk and no exit plan. And I'm curious to see what the outcomes are with palliation alone versus rescue with the ablation. They may be the same, which will be disappointing for me, but we'll see. So this is really not something completely new. Paolo Della Bella was really the first one that created the DT unit in Milan at San Raffaele. And here the DT unit was really created to manage patients with a DT score. And they use a protocol that was very simple here, not very refined. So that's they use the type of DT that they have, the presentation with electrical slope incessant DT versus so-called paroxysmal DT, majority of patients, but then they just certify that according to the hemodynamic stability during VT. If the VT is hypotensive, then they consider mechanical hemodynamic support. Typically, they use PA ECMO for these cases. If it's is tolerated, of course, they can consider not using it. But again, this workflow is actually very intuitive and doesn't really tell us much about risk stratification beyond the clinical presentation. So, in fact, in 2009, there was a consensus document for VT ablation. And here, there was absolutely no recommendation for how to stratify patients with VT coming to the ET lab. And all they said is they have careful attention to food balance and ability to manage food administration is recommended, but there was no recommendation, no evidence for pre-procedural risk stratification. This was 2009. 10 years later, this is a new consensus document. And now this one states that you can use two different ways of risk stratifying patients. Either the pain score and the Seattle arterial model are recommended now for pre-procedural risk stratification in patients with structural heart disease undergoing VT ablation. We'll talk about these risk scores in detail, but again, a lot of things have changed in 10 years, which is great to see. And the reason why they changed because we were always concerned about these type of patients that we got, the tertiary referral center and but also Cleveland. These are really the rule for us. 67-year-old male with ischemic cardiomyopathy and ejection fraction 15% presented with VT stroke, 67 ICD strokes over 1 month period. So typically, this happens a lot. This in the US, there's always an attempted ablation somewhere else, and typically that in this case, the study that stopped because of incessant VT and hemodynamic instability. Patient was intubated and stabilized with pressors after 3 days. Not considered further attempt of VT ablation for University of Pennsylvania until 2014. In incessant VT, despite lidocaine, amiodarone, intubation, and sedation, these are the patients that we used to receive. And of course, the problem with this is that most people, if you talk to some investigators, they say this is not a problem because you can actually just do substrate-based ablation without induction. The problem with that everyone who does these cases realizes that sometimes substrate-based is just not possible because as soon as you advance the catheter in the ventricle, you may have an incessant VT already to begin with, but sometimes you can have multiple VTs just with catheter manipulation. So it's just not possible to ablate in sinus rhythm or case rhythm. In these cases, because the patient is in incessant VT. And in fact, this is a problem that is also known, and it's again another study from Paolo de Bella, 528 patients for 634 procedures. But here, what I want to show you that 29% presented with electrical storm and 11% with incessant VT. By definition, this type of patients cannot be ablated just by leaving them in sinus rhythm because they're ongoing VT. And the other aspect why induction is also potentially important to understand what the VT looks like and where it's coming from, because there is a 5% of patients that have VT that has nothing to do with the substrate. So they present with ischemic and non-ischemic cardiomyopathy with a big scar, but the VT that is induced and is responsive to the clinical episode has nothing to do with it. It can be hepatic VT, cast region, for example, or protein related like this particular venture here in this case. So induction is still important. So going back to that, our experience, our approach was, which was typical at that time, to take the patient to the lab, and if something bad happens, then we ask for help. We ask for heart failure, we ask for cardiac surgery to implant them in hemodynamic support device. When we look at the data that this approach actually, the outcome is actually extremely important here. You can see that we had 80% mortality at 30 days, and the large majority of patients died within 10 days. This is actually the worst outcome ever published for VT ablation. This is a group of patients that presents with VT storm. We take them to the lab, and if they decompensate, then we go for rescue support, which is ECMO in this case. And if you look at the type, the only one that survived, first of all, are the ones that were able to be emergently evaluated for LVAD and transplant and made it to that. But here, what I want to show you is that the mode of death for the one that we had, most of them, that were really nothing to do with the VT. These patients are dying because of advanced heart failure. So just by looking at this data, we decided to modify the development approach to try to be a little bit more practical. But first of all, the first step was to understand whether we can identify upfront patients that may have this type of outcome. And this was the study that actually ended up creating the pain score. It's 193 patients, so not a large study with correlated VT, but we just looked at two outcomes here. And there was a lot of difficulty to get published for this paper because nowhere in the paper is mentioned how we did with the VT ablation, first time we didn't really look at that. All we looked at is a peri-procedural decompensation that was defined as sustained hypotension, systolic blood pressure less than 80 to 90 millimeters of mercury, despite increased doses of vasopressors and requiring mechanical hemodynamic support, either with intra-aortic balloon pump or with an impeller device in these cases, or the procedure was discontinued because of the compensation. As a secondary endpoint, we just looked at the low-cost mortality. Again, this was a lot of resistance to the viewers saying, why don't you look also at the recurrence? We didn't really were interested in that. We wanted to understand why some patients that we take to the lab have adverse outcomes, mortality, and decompensation. And here, when we ran the logistic regression analysis, we did find that there were these factors that were associated with high risk of decompensation. And here, the way we created a risk score was actually very simple. We took the odds ratio to the logistic regression analysis, just rounded it to the next interval level. So in other words, it was probably 4.7, it went up 5 points, and so forth. And here you see the first aspect is that some of this, most of this actually very intuitive, pulmonary disease, particularly COPD, advanced stage, ischemic cardiomyopathy, white-shaped plastic report, and so forth. But most of these aspects, actually, most of these factors cannot be modified by our ablation, by our approach. The patient already comes in with these factors, so there's nothing we can do really to modify that. The only modifiable risk factor is the use of anesthesia. And actually change a little bit our approach. We use less general anesthesia now and more conscious sedation possible, because we do know that the anesthetic will decrease significantly. Of course, the blood pressure and also make something that starts off as stable and without stable, we want stable. It's our experience, for example, that whenever we intubate a patient with PT, for example, in sinus medium, all of a sudden, he comes to the lab with no pressors, after intubation, and there are 2 pressors to keep the blood pressure up. So anesthesia has a negative effect in that sense. So when we look at the tertile score, and that's where the risk factors came into place, we have less than 10 points per tertile, second tertile between 10 and 16, and third tertile for the 70. There was a clear increased risk of acute decompensation of tertiles, but mostly this really happened to the third tertile. So whenever you have a pain score greater than 17, there is a 20 to 25% chance of acute decompensation during the procedure. And the other aspect that I want to mention here is that if you look back at this paper, actually, 60% of cases, the compensation happened not because we were making DT, just doing substrate mapping and ablation. Again, it tells us that substrate-based ablation alone may not be enough to just prevent decompensation. So what happens if the patient decompensates during the procedure? Here, I'm just looking at a couple of Myers survival curve, previous all society. It is a clear separation that happens very, very early on, within 6 months actually of the procedure. And there's a much higher risk of mortality for these patients compared to the ones that didn't have decompensation. Most mortality events happen in the first month of procedure. End-organ perfusion is another important aspect. And here we looked at another factor that's actually very well known in international cardiology, the occurrence of AKI post-procedure. Here, AKI was really defined, which is standardized is a 0.3 milligram per deciliter of creatinine over 48 hours post-procedure, or an increase more than 1.5 times the baseline value. These are all validated. It may not sound that much, but this is a very validated way of defining pre-procedural AKI. And here is a group of patients of 317 with steroid PT. And here, if you do have AKI, again, mortality is significantly increased. AKI adds up to the pain score to determine higher risk of mortality, particularly 30-day mortality. So then we create the pain score was defined with our database at University of Pennsylvania. The question is how is externally reliable this is and how we can generalize that to other centers. So here, what we did, we just took an IVTC's registry, which is a registry of 1,061 patients, 12 institutions in the United States. And here we just looked, we didn't have the data for the compensation, all we looked at the early mortality. Mortality happened between day 0, there were 2 interprocedural deaths, all the way up to day 31. The reason why I chose day 31 as opposed to day 30 was there were 3 patients that died on day 31, so I wanted to include those events in the analysis. Just to start. What I want to show you here, first of all, that the incidence of early post-procedural death in the ablation is 5%. And it kind of like progressively increases with time, is up to 5% here. But again, if you compare this to what cardiac surgery does, it's actually higher than average and valve surgery combined with most centers. So this is really the highest risk procedure that we do in cardiology and cardiac surgery.
that's something that needs to be really said about that, and that's why it's so important to improve the outcomes of this specific group. And when we look at the pain score, he was able to differentiate patients that have early mortality between day 0 and day 31, late mortality between day 31 and 1 year, and the survivors. So again, the pain score performed well, even in this multi-center graduation. Similar to this, we looked at the mode of death, and similar to our data, the majority of patients died for cardiac non-VT related death, which mostly was heart failure. And again, even if you do a good job with the elimination of the VT, these patients still have a high risk of dying from heart failure. And one aspect that actually was right there, I'm looking at this more in detail now with another study to try to understand that really there is impact. In these patients in particular, any periprocedural complication will increase the risk of early mortality by a factor of 4. So that's why I think it's very crucial for any of these patients not to have any periprocedural complications. The first really improvement in outcomes that we can make a meaningful impact on, not so much about how we get rid of the DP, is more to prevent periprocedural complications. And then we look at the type of complications, it seems that thrombotic complications are higher risk compared to bleeding, but again, this is underpowered. But here I want to show you is that periprocedural complication in these group of patients extremely is a problem, right? So it's a problem in any patient that we do, but in particular, it's been associated with an increased risk of early day mortality. Once the pain score was developed, then we looked at different types of risk factors and risk scores to predict mortality and adverse events in heart failure. Here is a group of patients with clinical neuropathy where we just studied systematically all these scores, and that's why the Seattle Arterial model actually got into the guidelines. Because after the result of this study, we realized that the Seattle Arterial model was actually even better than a pain score with an AUC of 0.89 versus 0.83. Pain score was the second best here. All the others really not that great. The problem with the Seattle Arterial model, it includes a lot of variables. Some of them are not easily available. That's why the pain score is still, I would say, the workhorse of this certification. Very easy to calculate bedside. Most patients already have those data. So here, if you look again at Seattle versus pain score, it was quite surprising that we expected versus observed mortality rate actually very similar. So this model was actually very well fitted. But mostly what I want to show you, the third quartile were patients that had high risk of adverse outcomes. So the first two quartiles with not much separation is the third one, with 17 for pain score. And for the Seattle Arterial model, I'm getting exactly how much it was here. That increased the risk of adverse procedural outcomes. So one aspect that we were interested in then, if we prevent decompensation with some form of intervention, what is the outcome? Here was a propensity match analysis with Impella CP, which is vascular impella, transfemoral impella that we use. In 150 patients, 75 with Impella prophylactically placed before the decompensation happened, and the control group with Impella. And there was a reduction, seemed to be a reduction here in the risk of decompensation. There was not an abolition, there was about 5 to 7% of decompensation that still happened. And we hypothesized here that if you use a better Impella, a higher flow device, you even reuse this problem. Sometimes the policies that don't get confirmed, but more to come in the future, but that's what we'll see. So what I want to show you here, the other aspect for fluid management that we investigated, also intraprocedural operation. And here, most of these patients presented a very high dose of basics and so forth, so they can really tolerate any overload. In these cases, in addition to hemodynamic support, we'll be using also procedural operation to get rid of the extra fluid from our mapping catheters and ablation catheters. It was the first study we ever done. It was actually 2 patients here, and then we're trying to do this more systematic. But going back to that, here we found with Impella propensity match, there was no difference in this study in terms of the interior curve, but surprisingly to us, there was a difference, there seemed to be a difference in terms of death and transplant over follow-up, which seems to indicate that it prevents the compensation, you may have impact, not necessarily a VT impact, but impact in terms of use death and transplant. And when we look at the subgroup analysis, the one that really benefited was the ones with a high risk of the compensation based on the patient. All right, of course, we do our own Impellas, so therefore it's quite crucial. We looked at the reason why sometimes we don't have benefit. One of the reasons is the procedural complication comes with it. So we screen all these patients out most of the time to see and to understand how the vasculature is and to decide where the stage should be. In this case, you see the bifurcation on the right is much higher. You can also see that with ultrasound, but you cannot define the that's why CT probably is the best way. And of course, proper vascular access is quite crucial. The other aspect that can happen in this case is, of course, you can use arterial possibility because the sheet being occlusive. And the way we monitor that in this position, our pulse oximeter very simple to put here on the left side, but in this position. And if there is continuous flow there, you will see pulse oximeter at the level. Occasionally, you do not have flow, like in this case, and here you see the impella sheet is completely occlusive. So the way you can overcome that is by using the impella without the sheet. There is a way to do that. But also, we also looked at, sorry, I don't have the data here, but you can also create a sort of femoral plate bypass by including another anterior sheet here and connecting the impella sheet to the anterior sheet in this case. Again, there are a lot of things that can be done. But again, when you get to this point, usually it's not, you cannot afford to stay in impella for a long time because of this vascular complication. All right, so another aspect that we looked at is whether we can actually use a multidisciplinary approach in the sickest patients, the one with biventricular failure. The one with biventricular failure is important because impella alone will not work. We only have to support device. This patient decided to do that. But here, we just created a pilot study with a stepwise approach, where step one was just admitting patient to the ICU for hemodynamic optimization and support, and to assess those candidacy to advanced therapies. Step two was in surgery that evaluated the vascular access with the CTA and ultrasound, and then elective initiation of the ECMO. Either we use femoral artery to femoral vein in case there is no PAD, but in patient with PAD, the cases with axillary artery to femoral vein. Of course, we use the axillary artery opposite to the side of the device of the ICD, and then catheter ablation. Step three, we take it to the live ablation. And then sometimes we do NIPS, non-invasive stimulation the next day, but still maximum to decide for additional ablation before we do elective ablation. And here, with this approach, simply involving multiple specialties in the treatment plan, we found that our institutional outcomes were significantly better than the one that I showed before, 76% mortality down to 11%. Again, this is just a pilot study. We started a similar effort in Cleveland now, in a prospectively collecting data. So, of course, this is being replicated by the standards. Here, if you look at this specific study here, where out here, basically, this is a group of patients that didn't get the LVAD heart. This one that had rescue versus preemptive, and if you look at the 30-day mortality, much higher rescue group versus the preemptive mortality, and so forth. So why we believe initially that preventive LVAD may be beneficial to the population. Again, this has to be, in my opinion, proven in randomized trials, because again, these are all retrospective propensity matched. But there are some potential benefits. You can maintain vital organ perfusion, reduce intracardiac filling pressure, reduce the LV volume, the most stress sensitive too. You will augment coronary perfusion, you will support the circulation, the ablation, and potentially you will reduce the cardiac stomach, secondary to multiple reductions and memory. So if this is all true, then why don't we just go with the best we have, which is your newest impella high flow with 5.0, 5.5 liters per minute. And this was something that we presented at A20 actually at the Liberating Clinical Trial at HRS. This is a first segment series. We ended up in 41 cases actually, impella 5.5 compared to a propensity group. And I can just anticipate that the results are not as good as we thought. Okay, and you'll see more to come. I think it was actually surprising what we found in this study. So other aspects that you want to make sure, you want to monitor continuously the intracardiac pressures during the procedure. I personally like to monitor both the CVP and LVDP of the left atrial pressure to understand how much fluid and what or how the procedure is going and zero oximetry. And what we do also now, we have introduced palliative medicine. The mix of this, and here basically that's what we're doing at Cleveland now. We have a standardized management high-risk patients. All patients that Painesd low ejection fraction will be automatically consulted by heart failure. This doesn't matter if the patient or outpatient heart failure see them beforehand. And if the Painesd score is greater than 17 with left ejection fraction less than 30% and no advanced therapy option, Then we meet all together, kind of like an LVAD, a heart team meeting. We have EP, we have heart failure, we have cardiac surgery, cardiac anesthesia, whether we decide whether the patient should be actually taken to the lab or not. And then we discuss with family. If some families say, okay, do everything you can, that's some rescue operations. Some others don't want to do that, and we go just for palliation. We need to really understand what the outcome is in these two groups. So I'll conclude here saying that in patients with structural heart disease, a pure structure-based ablation approach is not always possible. I love to do it when that's possible, but it's not always possible. Therefore, periprocedural decompensation is a major concern. Can happen also during structural ablation and can dramatically increase short-term mortality. It can be predicted. The pain score has been developed to predict specifically decompensation and adverse procedural outcomes. Prophylactic hemodynamic support in these patients may be beneficial. Say maybe, but it's not a free ride and yes, with high complication rate and needs more data. Waiting for the compensation to occur though before you start hemodynamic support, basically the rescue approach is wrong. We found that in multiple studies now we try to avoid that as much as possible. And in patients with high pain score and no arterial strategies, it's also reasonable to say no. Basically after discussion with teams, colleagues, family, and of course these patients, even palliative medicine option. I'm going to stop here. Thank you very much.
Thank you very much for this great talk, Pasquale. ¿Algunas preguntas del auditorio? Por favor. Carlos.
Have you explored any markers during the procedure to prognosis and compensation? For example, the amount of scar or the amount of ablation that you will need, or AV block during ablation, because maybe there are some patients that with the Painesd score, the score is low, and you think that the procedure is going to be well, but during the procedure you see a big scar and you need to do extensive ablation, and it will compensate during the procedure. Have you explored this kind of marker?
Actually, the scar size we haven't looked at with voltage. There's actually a study that Jeff Winterfield has done in South Carolina where they use that stuff. He's impressed. They use scar size on CT scans and MRIs, basically procedure. And if you add that to the pain score, exactly as you said, it does improve the predictability for the complication. During the procedure for us, it's quite fast actually to get up a map to understand how big the scar is. And because you're right, the scar is actually quite extensive. And not so much the bipolar, it's more of a unipolar scar issue more than that. It's something that needs to be looked at, but I think that will increase even more the predictability and efficiency. And in terms of what to do during the procedure, we try to monitor them with one catheter with 7 nano. That was really great in terms of predicting the compensation itself. Of course, if there is an upward trend in the intracardiac film pressures, at that point we tend to stop, in particular when the prolonged procedures. And this seems to be a cutoff within 4 hours where the risk of the compensation tends to occur during the procedure. So we try to go sufficient days with these procedures. But again, we don't have a lot of data on that yet. And heart block, I mean, sometimes that happens just because of the basal septal substrate. We have not specifically seen an interaction with compensation with that, but I mean, something to investigate if we go to some patient. So.
How do you choose
Yeah, so it's mostly related to the degree of RV failure, concomitant RV failure. There is a lot of significant RV dilatation and dysfunction. We tend to go with ECMO, although we have to say within Ella, if you leave them in for 1 or 2 days beforehand, then the RV failure also proves because naturally that's what happens. Not that much, not to the same level of ECMO. The problem with ECMO is that the cannulation is actually always complicated unless it's entirely unelected. So, sorry. Central we haven't used that one yet. Yeah. But there was 1 or 2 cases with tandem heart, but we didn't like it either because big cannulas, etc. Mostly the way we do impella, well, we only support for a ventricular support. There is also another impella that is right side that support impella, but there's a lot of interaction with the magnet for us, so we don't, we can't really see also if we get a echo there, we don't like to use that one.
We don't have impella. How it is to is intraarticular
Did not use. For patients with coronary disease, maybe it's helpful in some ways, it's better than having nothing, but really, I don't think the data are out there to support that. And in fact, the one that I showed you, we stopped using balloon pump after the initial implementation paper because we found that it really
So if you have to use ECMO, for example.
Thank you for your excellent conference. My question is about the post-operative management of this kind of this post-catheter ablation. All these patients arrive with a KUB in having mechanical support, plus vasopressors, plus eye drops, and all these medications are very acute. So we should try to stop as soon as possible these medications, these vasopressors, and instead start the blockers. And the second part of the equation is about the antiarrhythmic. Do you use the antiarrhythmicals in post-catheter ablation in basis?
So the third question is, of course, ideally you want to be off pressors if possible. Sometimes it's not really possible to do that. And you're right, there can be an interaction with the amount of pressors that you use in either curves, the arrhythmogenicity that you see during the procedure, but also after the procedure. And the other aspect was, sorry, what was the other question? The second one was the. Yeah. So yeah, so it depends on the acute outcome. We achieve non-inducibility, we target full stop state. We tend to reduce initially the antiarrhythmic use. If it goes to use it for usually 1 or 2 months. And if they're doing well, then we stop it. Otherwise, if there's still persistent inducibility, we manage that better. But mostly is a myelofibrosis disease.
And I have like 2 questions. If you decide to use ECMO, you use central or peripheral cannulation? Because for us, it's kind of a big problem because we have to do this procedure as an elective one. And probably it's like, you don't have to, I mean, you don't really want to have a lot of time with these patients on ECMO because of other issues. So which one is your approach for this kind of procedure?
So we do peripheral cannulation, right? That's our go-to that we use. And central, we have not really necessarily used it most of the time. We try to limit the amount of peripheral cannulation. Of course, we have to be very, very quick with the implant and explant because there are problems with that cannulate, but we try to limit the amount of exposure to that.
And for example, when we are talking about patients that are not in a like an urgency place, you know, like without cardiogenic shock, you are going to do this as an elective procedure. How many hours before you use the preemptive option?
Well, it depends on the clinical status. They can do this outpatient, so they're relatively well compensated by the high risk. We basically do that in the morning of the procedure. We do 2 or 3 hours on ECMO, make sure there's no bleeding, etc. And then we do the procedure right away. So now, when we do the procedure on ECMO, we always try to limit the flow as low as possible and maintain the possibility of the heart constantly. So that's very, very important because otherwise what happens is that actually we counterproductive in some ways to use it. So we use a very lowest flow available and we keep ablating mostly normal breathing, BPAs or silent breather, maintaining the possibility to look at the, of course, feel away from, but also because the where the ventricle shape changes, intracardiac pressures measure, and also we see the aortic valve always open with that because we don't want to go too high for that, otherwise it will become black.
Thank you.
I have a couple of questions for you, Pasquale. In those cases in which you decide to start preemptive hemodynamic support, what is your workflow to do? So do you prefer to start ECMO, for example, in the intensive care unit or on the hypergroup. You know, this is very important to say in terms of efficiency, etc. Do not delay the procedure. Do not spend time without upgrading the patient, etc. So how do you do it?
No, yes, we try to do it in a different room when possible, take it to the lab, but it's still not the OR. When I'm showing ultrasound for access and everything, there's no orthopedic surgeon actually does that. So we're really participating in that time to make sure that there is almost no issues with vascular access. And after we do that, we initiate ECMO and then we transfer them to the lab. Sometimes what we've done everything in the lab. So they come to the lab, we do access for them, and then they just exchange with the sheets, and then we start to see right away.
Okay, any issues about anticoagulations? Because once you start ECMO, for example, and you need to go to an epicardial function, for example, obviously you're scared about accidents, etc. How do you?
So if you decided before the procedure, like in the OR and the transfer to us, we always ask them to go with a small epicardial, even if the issue's never been ablated before. So basically what they do, they just like dissect, just open up the machine and then close it. So for us, that basically is already closed. But because we don't want access on the heparin, that's for sure. We try to avoid that. If we do it in the EP lab, which is now 70% of cases that we do the access first, and then we do the ECMO migration.
Access through window.
Epicardial. No. Within the epicardial access.
Puncture.
The puncture, yes.
Okay.
And then we do the ECMO migration or the migration after the heparin.
Okay. And what about in those cases in which it was already started hemodynamic support, preemptive hemodynamic support, and then the patient came to the lab? So window.
And well, for those, we already asked for them, or rarely we like we or we have but again, it's not advisable.
Yeah. So what about the performance or the predictive value? You know, for the hemodynamic, acute hemodynamic decompensation, depending on relative to the cardiac disease. Is it the same for non-ischemic or ischemic? What about Chagas, for example? I know there is a publication talking about the applicability of pain score to predict hemodynamic decompensation in Chagas disease. And apparently, it's not the same compared to.
Yeah, so if you look at the pain score itself, one of the variables is ischemic cardiomyopathy. The reason why it's there is we found much more frequently that pain. When ischemic, especially like that, then it becomes complicated to see. He still performed well, and that they were just ischemic, but most of them were LV and idiopathic dilated cardiomyopathy. Most of them. We have really no data for Lamin, for Titan, for all the indications that are Chagas. So I'm not surprised that it's not going to be perfect for every single one. And mostly that's why one of the variables is ischemic cardiomyopathy. But I know about the publication from Brazil, right?
Yeah.
Yes.
Have you used ECMO or any other mechanical support during rescue ablation in patient with no cardiac plan, just for recovery after ablation?
Yes, but the outcomes are not great with that. So in that case, it's actually paradoxical. Whenever we go for ECMO or that support, we always do it when we have more aggressive or we have an exit plan. When we don't have an exit plan, actually, we try. Sometimes we've done like a few cases of test and patient compressor, it's kind of like a rescue bailout approach, but it's really not a great idea. Once the ECMO in Bella goes in, then you have to cannulate. Think about that. Some of these patients actually without time, without being able to be the cannulate after the procedure. That's why we kind of stop with that if there is an active plan.
Thank you, Pasquale, for coming and for being here. It's a pleasure and privilege to have you. A question maybe going not exactly a huge setting of the compensation be sold, but maybe 2 or 3 months before. How effective were you in to get all the patients with advices under the scan with a big very group? They have a great team. And how effective are you at Cleveland with the reform? I know wideband use is basically universal in the US for clinical purposes. We don't have it here, believe it or not. It's been quite a headache for getting. And since they came here, David versus Luis and the whole EP team and now the heart rate, bugging me, obviously, justified itself for not having it. We just don't have it here in Latin America. What percentage of your patients do get diagnostic imaging with banding that can prevent, getting into the acute setting again?
Yeah,
Further
so
conversation.
I don't have an exact percentage. I tell you that it's still even with white band, there's still an issue with that. Some patients don't have full diagnosis. We can image the full, mostly the anterior wall, the hand is right there. Or for patients like cutaneous ICP, those are another issue. So roughly, so for the sector, particular, we're able to see it fairly nicely for most patients, I would say 70% enable that. But for others, I think it's still close to the 50% who will be able to be fully imaging of that. The other aspect of it is that scar on the MRI doesn't always correlate with the site of fetal disease, which is a kind of like a little bit challenging for me to understand. I'm trying to investigate a little bit more of that because there is this push to do MRI imaging and then do radiation therapy based on that. I think they can actually, without matching the patient up front, I think that may be actually a mistake. Because, sometimes we can be off by 1 or 2 centimeters when the MRI sees most of the dense scar, and you may not get rid of the problem because radiation therapy based on that. But yeah, so that's our numbers. We're also looking at late iodine now and CT wall thinning with CT scans. Again, that's still open questions. And whether it's necessary, the way I look at imaging, I just look at the imaging with my colleagues from imaging, and I just try to understand whether it's intramural versus not, angio versus vertical. It makes a big difference. But then I don't necessarily use it as an integration in the lab. So it's just because sometimes there is an issue for the quality of the images. Did I answer the question? How much is it here?
We don't have it.
We don't know, but when you do it, what's the liability?
Oh, so Boris is going to answer that question in terms of what's the correlation between the two of them. But I'm a little bit shocked that you don't find one as helpful as we were.
No, it is helpful, but it's not the solution for it. So
it's not a gold standard.
Yeah.
Another question. In this high-risk patient that you are planning to take to the EP lab, but you need, I don't know, maybe a few hours to make decision. Have you used bridge therapy with sympathetic nervation, and what kind of therapy do you prefer? Stellate ganglion or peridural anesthesia? What do you prefer?
Yeah, so usually we use percutaneous ganglion block. Anesthesia does that with that. It's only temporary. We've been using that, yes, with some mixed results, I would say, but sometimes we use that when we have other options. But yes, that's the only thing we do.
And in the second line of treatment, if you have recurrence during DIPS, what do you prefer? A sympathetic denervation by surgery or maybe cardiac renal denervation, or do you prefer to take back to the lab?
Depends what was done before, really. We review the case, first of all. Most of the time, there's always something more that can be done. So usually my bias is always to get later. But yes, so that's my personal bias. I know it's not easy to accept sometimes from me or for the other operators that have the first case, but we are limited sometimes. We don't do so much one session. Just doing the game gives the extra benefit. So.
Pasquale, how is the communication process inside the heart team to decide what to do, when to start preemptive, etc.? Because obviously those are critical patients. Everything is happening very fast. So sometimes all the personnel is busy, inside the lab with other patients, etc. So how you are facilitating this communication process?
All right, so we have a PT round every Monday at 5:30 for inpatients, and then for outpatients every Friday at 5:30. So that's where we review what came for the weekend, what the plan is for the week. That's for the old division. So for inpatients and outpatients. So the cardiac surgeon and the heart failure team actually participate to those, and we can review together. We're not always, we ask them to participate. Most of the time, we just between our EP colleagues, we decide what to do in terms of the procedure. But we have that. And then if patients come in between the week, then we have another informal meeting, usually via email. That we call
call each other. Like the formal meetings are always Monday at 5:30 p.m. and Friday usually around 5:30 or 6 p.m.
And I suppose you have like a standardized protocol facilitated the making decision process.
Yeah, so basically there is one nurse practitioner that reviews all the patients, okay, and he sends an email with a summary of patients to be discussed what the issues are, and then he presents the patient to us. It's a team's meeting, the virtual, so everybody's in their own office like that, and then we discuss together what the plan is, and also we look at the lab schedule to see which patient goes where based on the timing that we have. Some patients may take much longer, and the cardiac. So, and that's also we discussed that.
And how is your workflow to stop the hemodynamic support? So, how is the communication process again? Because you have to take in mind not just the hemodynamic behavior of the patient, but also what happened with the arrhythmia. What is just suspicious to get more recurrences, etc. So, I suppose you communicate very well with them, but how is that?
So typically we try to, at the end of the procedure, to go back to the same level of pressure the patient came in with before the procedure. If that's not possible, sometimes we have to leave them in a little bit longer. But if that happens, then typically the patient gets assessed even overnight or early next morning, whether they can be ventilated, and that's it. Typically, in these cases, whoever is in the ICU does a quick mix test. And sometimes, to be honest, it's not like a full protocol, but just to understand if we have VT usable with like singles or doubles, or repeat the same type of protocol, other issues. And then at that point, we go for the cannulation. So we try to be very fast with that.
NIPS refer to non-invasive program stimulation through the device, the ICD, to prove if the VT is still inducible or not. So, acute hemodynamic decompensation is a strong predictor for mortality. Obviously, in hospital and long-term follow-up mortality. So, but those patients are very sick, the patient who presented that. So how is the care after the VT ablation? How you also agree with the heart failure team, for example, what patients need specific care or, another measurements, change in medication, etc.
Yeah, so if we go for a ablation procedure, so everybody in the entire team is on the same page and do everything they can to improve the outcomes. In other words, sometimes may happen that the patient is more decompensated than either procedure. So they really have to go the extra mile to do everything they can to rescue that. Because the fact that we did that procedure actually select the patient we wanted to do everything they can. So the communication in that sense, if you go on the heart failure, there's always an arterial attending overnight actually, and they always look at them in the setting of the ICU. So they and basically they try to do their best to rescue the problem. There's a new problem happening, but typically this has not been the case. Just one word actually about NIPS. I just reviewed the data that we have. It hasn't really made a huge impact in terms of the decision making. So in other words, what I'm trying to say is that sometimes we do see some other non-clinical VTs with NIPS at night, but that hasn't really changed our approach in terms of ablation, because sometimes we have not really taken that back to the lab. And looking back, it's been 6 months now, we haven't found a significant difference in outcomes with that versus doing it. So we were thinking about dropping that aspect of the procedure, because if you do a good procedure and you get good non-invasivity, then you know how much is actually recovered. So the operator knows already how good it was. Then usually that should be good enough even without it. Yeah.
Okay. So you showed us that preemptive hemodynamic support, more than rescue, could change mortality, long-term mortality also, right? So why? How do you explain that? Yeah. It is because hemodynamic support allow you for better ablation, or what are you changing to decrease mortality, even in the follow-up, in the long-term follow-up?
So I think one potential way would be to prevent the competition to the procedure and therefore prevent the impact of the competition as of mortality. However, again, it has to be proven in a prospective way, because whenever we try to give better devices we actually haven't seen the same results. What we have seen actually, we've seen much more complications. That's what we've seen. See that, and that it stems from two reasons. Of course, if you go with a bigger device and it needs cardiac surgery, you have to go with the axillary. That actually adds a lot of complexity. The patient is already complex. And all it takes is a hematoma here of the shoulder, the axial side of the patella, to tip the patient over on the other side. The second aspect that I think is important, the fact that you have an hemodynamic support device in place doesn't allow you to be like a cowboy during the procedure and just keep that PT and just because you can do that, but then you pay the price afterwards. And that's the second aspect that we found with this study with the nature. So.
Okay.
If you have advanced heart failure, which one do you think is stable? And you prepare this patient for an ablation. Do you have any hemodynamic measure to decide which patient goes with preemptive arm or all of them goes with preemptive?
Well, we've been doing most of them get a rather cut before the procedure to understand what the index output is, and also the intracardiac filling pressures. And based on that, it's actually the anterior field that tells us what they think in that sense. So if there's a patient that needs benefit more, they tell us. And not every patient with a pain score greater than 17 will get hemodynamic support. Because some patients actually, that those risk factors are still actually with intracardiac filling pressures, etc. So we don't do that. So really, we have a collegial meeting. And really, the one that make the decision that sense is actually your colleagues, the way they think, and rather than us. So, yeah.
What patient with BT in the first episode you choose the BT ablation as the first line therapy and not putting a ICD and amiodarone and go home?
Well, it depends on a lot of things. I think it's a good question. In terms of the clinical data, there's really not a lot of evidence for first-line ablation. There is some, like either it's a theta trial that is a raw time. But the problem with that is that every patient, if you have a young patient with sustained monomorphic small substrate and relatively preserved ejection fraction, let's say 40% or so, in those cases, I think it's better than ablation than amiodarone. If you have a patient that is 88 years old with 15% EF and cardiomyopathy for 30 years and one episode of PT now, that's a different story. So I think you have to really judge. There's no right or wrong answer doing one or the other. I think ablation can be done safely. On the other side, I also don't think that amiodarone is actually like a terrible to avoid. In some cases, it's fine to go on amiodarone, and so you have to individualize it.
And you consider the etiology of the heart failure to define this BT ablation as the first line therapy?
Yeah, so of course it depends. If you have an ischemic cardiomyopathy, you tend to have a low threshold because we know exactly what the substrate is, and we know that they do well with ablation. For those, the threshold is lower, depending on other comorbidities, so ejection fraction, kidney disease, etc. For non-ischemics, ARBC, all patients that we understand the substrate, basolateral, LV triple, non-ischemics, etc. We know how to target them. We know the outcome great most of the times. For the septal scar, in those, you can decide what to do. It depends also if you have a septal scar from idiopathic versus climate versus other conditions. You can decide one way or the other. Because we know that the outcome of ablation is great. And even if you have a successful ablation, this patient will probably have a heart failure in that perspective after ablation, anyways. So that's why we individualize based on that. Not so much etiology, it's more a substrate distribution than anything else. Yes.
What do you think about ablation in chronic atherosclerotic disease patients which are being treated only with medical treatment and not revascularization?
Yeah, so if it is sustained monomorphic VT, so like sustained, there's no polymorphic, no VF, etc. Revascularization doesn't make it really much. So that means you have a fixed substrate scar. In fact, we looked at that recently in terms of
the understanding whether pre-procedural angiograms or ischemic evaluation makes an impact in terms of outcomes or even mortality, there was no impact. So we tend not to. Now, if we know that the patient is a critical vessel disease that is not vascularized for whatever reason, then we modify the way we do the procedure. We avoid induction in VT, avoid, for example, to have prolonged procedures, and also we monitor carefully the blood pressure because that can create ischemia itself. So we are careful with that. But there is no evidence that vascularization helps to sustain one.
We have our last question. It is about invasive monitoring inside the VT ablation. Do you use pain score to define that? When to do more, when to do less, depending on pains.
Yes, so more than that, we monitor actually the intracardiac pressures, the CDP and the LVDP give you a long sheet for educator, although not 90% of my cases are all placebo now, non-preventive pressure more than anything else. And if there is a stepwise increase, usually 20-30% from baseline values, that's a sign that we're really like going in the wrong direction. And of course, we monitor ABGs usually every hour for that. And in that case, we try to even like increase the amount of the races where possible, like basics, etc. Or sometimes we stop at that point. And the pain score correlates with this in a way that typically patients with high pain score also have high intracardiac pressure. But we don't use the pain score alone. We monitor the pressure pretty much in everyone, just to understand how much fluid, etc.
Bueno, muchas gracias a los asistentes y por sus preguntas, su interés. A lo largo del día vamos a tener diferentes reuniones con grupos como de soporte hemodinámico y fellows, etc. Thank you very much, Pasquale, for a great talk and great interaction. Thank you. Bye.